Hey guys, Miss Hill here, and I am picking up with Lecture 3 on Individual Module 6, PowerPoint 1. We're talking about newborn care, and we left off the last lecture at assessment. Regarding the nursing process, and I told you guys to go through the assessment piece on your own. There were several slides there, 26 I believe to be exact. We already did assessment in our sim lab day, so I'm not going to lecture on that again. I feel pretty confident that you guys can read that and move through your PowerPoints and have a good understanding of that. So we are picking up with diagnosis in regards to the nursing process. And there are several nursing diagnoses that can be appropriate for the newborn. We can have ineffective airway clearance, ineffective thermoregulation, acute pain, ineffective breathing pattern, and the list goes on and on. Because their systematic changes are um, so sensitive, and because their systems are so underdeveloped as a newborn, immature, um, there are tons of nursing diagnoses that can apply to the newborn period, but you have to understand the processes of what are happening physiologically from a systems standpoint to be able to apply those nursing diagnoses to the newborn. So from a planning standpoint, obviously our goal in this class, as we have said over and over, are healthy mom and healthy baby. So we want that newborn to be healthy and well. And we also know that this course is called Family Health Concepts. So we are not only worried about the well-being of the newborn, but we're also worried about the well-being of the family unit and how they are going to function. Remember that birth and adding a new family member to your unit is a time of maturational crisis for these individuals. So the family has to learn how to adapt, whether they have 3 kids and they're adapting to the 4th one, or whether they are just a couple who are moving into being parents for the first time. So assessing attachment to the family and how the family unit is taking in this new member, and looking at how bonding is happening between the family members, and if you can sense any turmoil between some of the support people. All of this is very important when it comes to goals and planning and helping the family move forward. So when we talk about initial care of the newborn and our implementation process, many of these things we have already talked about in the PowerPoint, so I probably will go through these kind of quickly. But initially, we're going to check and confirm identification of that newborn. We're going to place bands on the newborn and the parents and make sure that we can identify them and be able to link them together. We're going to maintain a clear airway. We are going to position them on their back, suction their airway if we need to. We might have to use a bulb suction. We may have to use a deeper suction, but we're always going to move from mouth to nose. We are going to report any type of excessive secretions to our primary healthcare provider. So if we're doing deep suction and we are getting tons and tons of secretions out of the baby's lungs, there could be some type of problem going on that needs to be looked at, diagnosed, and treated. We're going to measure vital signs every 30 minutes until their condition has remained stable for a couple of hours. Or you're going to follow your hospital's policy, and it can be different from place to place. We're going to promote thermoregulation in the newborn, and we're going to provide them with a thermal neutral environment. We can best achieve that if we do our interventions skin to skin with mom and our newborn is nice and dry, or if we have to move the baby to a pre-warmed radiant warmer to perform some of our interventions. Um, we are not going to bathe them until their temperature is stable, and we will always reassess their temperature after we give them a bath to ensure that they have thermoregulated after that process as well. And remember, a neutral thermal environment does not mean that the room is at a certain temperature. A neutral thermal environment is very individualized based on the newborn, and it means that they are able to maintain a homeostasis and a normal temperature at um, the most minimal level of oxygen consumption and metabolic rate for their body. From a medication standpoint, we're going to give these guys some vitamin K. We give it IM in the vastus lateralis, and we're going to do that because we know newborns are deficient in vitamin K and they need that for clotting purposes. We're going to also give them some ophthalmic ointment in an EES medication, and we do that prophylactically to treat any type of eye infections that they might, or any germs they may have come in contact with that could be in their eyes from coming through the birth canal or being born via C-section. We place that medication in the lower conjunctival sac of the eye, and it makes their eyes really goopy and hard to see. So it's okay to wait for a few minutes so that the newborn can look their mom in the eyes during that initial period of reactivity, and we can create some bonding and some attachment. But we do need to get it in there as soon as possible so that we can prevent and prophylactically treat any type of bacteria that they came in contact with. We want to make sure that we are assessing them closely enough that we can recognize any types of early signs of neonatal distress. Whenever you have a newborn that you are assessing and you wait too late or you don't recognize initial signs of distress, things get worse and worse, and they get worse very, very quickly. And they're much harder to turn around from an intervention standpoint. So we start by teaching parents. Number one, we teach them about temperature control and maintaining the baby's temperature by keeping the hat on them, keeping them covered up, keeping the room at a nice temperature. And we teach them signs of stress or distress. So if the baby is having episodes where where they're grunting, or you've got some nasal flaring or some retractions, we want to teach parents about that so they can recognize early signs and get in some intervention for those, particularly before once they're at home. So some interventions we can use are nasal and oral suctioning. Parents need to know how to use that bulb syringe. Positioning of the baby, so back to sleep, or if they're spitting up, we might need to lie them on their side with close supervision. You would never put a newborn on their side and leave the room or not be there at their bedside. Stroking their spine to help stimulate respiratory activity is also a good technique for you to teach parents. Newborns will hold their breath on you, and unlike individuals with a mature neurological system, newborns won't take a breath when they become hypoxic. they will hold their breath and keep their breath held. So if a parent notices that, or if you as a healthcare professional notices that, stroking their spine to help stimulate respiratory activity can be effective. Initially, also, as soon as the babies are born, if you notice, the nurses vigorously are rubbing those babies with the blankets and drying them off. It's not just that we are trying to remove the wetness off of their bodies, but we're also using that vigorous stimulation, tactile stimulation, to stimulate their respiratory response and adaptation to extrauterine life. It serves a couple of different purposes. We want to initiate the first feeding, and we want to do this during that initial period of reactivity, so that 30 to 60-minute period after birth. And sometimes the timing will depend on whether they're breast or bottle fed. Complications in the mom, such as diabetes or intrauterine growth restriction, can also affect the timing of when you want to feed the babies. Moms who had diabetes, those babies need to be fed as soon as possible because they will become hypoglycemic very quickly if they aren't fed. We want to encourage breastfeeding again during that first period of reactivity. And formula-fed newborns, we typically want that to happen by their 5th hour of birth. I don't know that I have ever seen anybody wait that long to feed their baby unless there was some type of problem that the nurse had to intervene for. So there was some type of adaptation problem to extrauterine life that required some serious interventions. We want to facilitate the parent and the newborn attachment. So making sure they're able to make an eye-to-eye contact, and also allow, if the moms can't get up and out of bed, allowing the dads or the partner to help the nurse give the bath. All of those things or diapering the baby or putting it in its first outfit, all of those things can help facilitate attachment. And are important for the nurse to consider. Once transition has happened, making sure that we can maintain a cardiopulmonary function in the neonate is imperative. So we want to be assessing vital signs very frequently, every 4 to 8 hours or more. Place the newborn on their back to sleep with a bulb syringe within easy reach so that we can get things out of the nose if we need to do that, or out of the mouth. Again, stroking of the spine to help stimulate respiratory activity if they tend to be holding their breath when they're crying or something like that. And for newborns who are at risk for a decreased respiratory or cardiac function, we may keep those guys on a cardiorespiratory monitor so that we can really closely and more accurately monitor this transition that is occurring. We want to promote adequate hydration and nutrition when we're talking about care of the newborn following the transition period. And we want to promote skin integrity as well. So for feeding purposes, we want to make sure that we record their caloric and their fluid intake. If they're breastfeeding, we record the time, how long they fed and which breast they fed off of, and we record behaviors. So if they seem satisfied, we record that. If they don't, then we would encourage further feeding and document that. We want to maintain a neutral thermal environment also so that we can enhance hydration and nutrition. If babies are cold stressed or if babies are hypothermic, they are not going to eat well. They're also going to be burning up all their calories to keep themselves warm, and they're going to become hypoglycemic. We want to initiate early and frequent feedings. We want parents to know how often to feed their babies. We want to record how often they are also voiding and going to the bathroom, or so we want to be recording all their pees and poops. And we want to teach the mom also to do this so that she can assess things once she goes home. We want to weigh the newborn. We want to make sure that we tell the mom that excessive handling can increase their metabolic rate. So picking them up and carrying them everywhere, especially if they're already at risk or a little stressed out, not allowing them time to rest will increase their metabolic rate and their need for feedings and their oxygenation consumption. And you want to be very alert for very subtle cues of fatigue in the newborn. So newborns who are a little difficult to arouse, who just will not suck, even though it's time for them to feed, those could all be subtle cues of fatigue. Assessing their comfort and their latching pattern if they are breastfeeding is important as well. From a skin integrity standpoint, assessing their bottle feeding techniques and bathing, or their bathing and cleansing of the diaper area and their care of the umbilical cord, all of those are important. When parents bottle feed babies, especially if they don't have experience, they may overfeed and the newborn, or they may be feeding the newborn too fast. They may not be burping enough. And if the baby starts to get a mouth that's full of formula, and then that formula starts to trickle out of the mouth and down to the ear or under the chin and under the neck, and then those babies are not cleaned up well or wiped down well, that can start to breed yeast and bacteria in those creases of their neck. It can breed bacteria in their ear and cause ear infections. So making sure that parents know this and assessing their bottle feeding techniques can help to clue you into education that may need to be done to prevent problems. Um, as far as the umbilical cord is concerned, cord care should happen at least daily, but definitely when it is sold. And we like to see parents care for that cord at every diaper change so that we can prevent infection. And we want them to know that they cannot submerge the baby in water until the cord falls off because of infection risks. We want them to keep that cord clean and dry. We don't need to put anything on it. We just can wipe it down with a little bit of soap, mild soap and warm water to keep it clean, and then make sure it's very dry. We want it to be on the outside of the diaper, so helping them to learn to fold the diaper down in the front is important, especially for first-time parents who don't know. We don't want that cord inside of the diaper because we don't want there to be a greater risk of it getting poop or some type of fluids on it. There's no need for any type of ointments or Vaseline or alcohol or anything like that any longer. We used to put all kinds of stuff on the cord, but we don't anymore. Again, promoting safety, so making sure that we have identified the newborn and that we have placed bands on the newborn and the parents, making sure that we're teaching the parents to check the ID bands of the newborn and personnel who come to get them, reporting suspicious individuals, never leaving their baby alone in the room. And even for moms who, a lot of moms lose a lot of blood during delivery. So if they feel weak whenever they are standing up or they're sitting up, encouraging them not to get up and pick the baby up, calling for help for someone to hand them the baby. But we don't want them, we also don't want them walking around in the hallway carrying the baby in their arms. We always want the baby in the crib if they're ambulating. And making sure they always have an eye and a hand on the baby when the baby is out of the crib. We don't want them to take the baby out of the crib, lie it on the bed, go to the sink to get something to change a diaper, and then come back and the baby is rolled off the bed onto the floor. And we want to encourage them not to allow visitors who have infections to come to the hospital or even to their home and see their baby until those people are symptom free. Hand washing is super important before and after contact with every single newborn from a healthcare perspective, but also from a visitor's perspective. We want to monitor for jaundice and educate the parents on how to do that as well. Circumcision is a very frequent procedure that we see in little boys. It is an elective procedure in a newborn. So if you have Medicare or Medicaid, that those insurances will typically not pay for circumcision because it is an elective procedure. But individuals with private insurance, that will typically pay for a circumcision. And even oftentimes, people who have Medicaid or Medicare, they are educated at prenatal visits that circumcision is not covered under their type of coverage, and they'll be told how much money it is, and typically they'll save their money up and pay the person who's going to do it. I've seen that happen a lot in my career. But circumcision is a surgical procedure which um, will remove the foreskin from the glands of the penis. And there is a lot of controversy over whether or not we need to perform that, but it's a very westernized thing to do. There are some religious and cultural um, sects that do not want this done. Jewish individuals are circumcised by a rabbi and not at the hospital. It's gained a lot of acceptance in the United States, and so it's a very westernized type of procedure, and it's become pretty normal. Contraindications for circumcision are individuals that are premature or the compromised newborn, or in the newborns that have a known bleeding problem. So we have a newborn that we know is not going to clot well. We would not do a circumcision on them. And then newborns who are also born with any type of genitourinary defect that would require use of the foreskin in some type of future surgical repair. So if you have a baby that's born with an epispadias or a hypospadias, which means the urethra is not in the middle of the glands, but it is either towards the top or towards the bottom, they use part of the foreskin to correct that defect in babies. So we would not circumcise a newborn that had that type of defect because they need the foreskin to make that correction. Parents need to be educated to make an informed decision whether or not they're going to circumcise. And if they're not going to, they need to be informed about how to keep the little newborn penis clean. So we need to instruct them on how to retract the foreskin and clean around the glands, and then always to make sure that you pull the foreskin back over the glands of the penis and not leave the glands exposed if they're not circumcised. Um, we perform circumcisions whenever the baby is stable and after there has been an initial physical exam by the healthcare provider. We would never do this when a newborn is transitioning to extrauterine life. We want them to take care of their respiratory and their cardiac transitions before we cut their foreskin off. Um, We would never also do a circumcision unless there is a consent on the chart and unless the person performing the incision has obtained consent from that family. Usually the nurse will witness the consent, but the physician or the person doing the circumcision, the pediatrician or whoever, has to obtain that consent. This picture shows you some of the different tools that we use in circumcision. There's something called a Gomco clamp, which uses a bell. It looks exactly like a bell. It's a metal device, and that bell is used to separate the foreskin from the glands of the penis. It's placed over the glands, and the foreskin is pulled up over that bell. And then there is an arm that is attached around the foreskin of the penis. The bell protects um, the glands, and then an incision is made, and the foreskin is extracted or excised. The Mogan clamp is a little more risky, I guess. It is basically just a clamp. The foreskin is pulled up over the glands of the penis, and this clamp, the person performing the foreskin, the circumcision, has to ensure that the glands of the penis is not going to be clamped along with the foreskin, because once the foreskin is clamped, a scalpel is used just to remove the foreskin. So if the provider has also clamped onto the glands of the penis, they could accidentally excise the top of the penis off as well. So that one's a little more risky to use. And then there's also something called a plastibell, which is just a plastic bell, very similar to the metal one that we use in the Gomco clamp. And it covers the glands of the penis while the foreskin is pulled up over that, and they use that to complete the procedure and excise the foreskin while protecting the glands. During the circumcision, the nurse needs to make sure that the physician has explained the procedure to the parents, that the parents have questions. If the parents have questions, that you are assured they have been answered and that the parents understand their risks and benefits. Verifying that the consent is signed and making sure that you have the correct newborn before performing this procedure. So yes, it is a surgical procedure, and a timeout has to be performed prior to doing this procedure. We want to prepare the newborn, remove the diaper, and place them on a padded circumcision board. We restrain the legs typically, and we provide them with some type of comfort during the procedure, whether that is in the form of a pacifier with some Sweeties, which is just sugar water, whether or not the provider gives them some lidocaine at the base of the penis to provide a local anesthetic effect, and then ensuring that the family has some comfort and can hold the baby after the procedure helps them as well. So they're very sure they want it done before it happens, but when they get the newborn back and it's crying, and they often become very distressed. And it's not advisable to allow them to come to the nursery to watch this procedure being done. Some of them will request to watch, but it's not advisable if you can talk them out of that. So caring for the circumcision after the procedure, the nurse needs to be assessing that circumcision every 30 minutes for at least 2 hours. We want to make sure that we don't have any bleeding issues. after this procedure is performed. So frequently checking the circumcision site is very important. We also want to make sure that the baby can pee. So when the parents change the diaper for the first time after a circumcision, you want them to call you. You want to utilize the call bell when they get ready to change a diaper for the first time after the circumcision. You, as the nurse, want to be there to witness that. Um, you want to teach the family how to assess for that bleeding and to care for the circumcision. We typically clean it with warm water after each diaper change. We don't want to use any type of alcohol-based wipes to clean a circumcision site. It is a fresh surgical incision. So be kind to these little people. And if you wouldn't wipe your, if someone had cut your skin off uh, and you wouldn't wipe yourself with it, don't wipe them with it either. We use petroleum ointment at the next few diaper changes, and we make a nice little ice cream cone on the top of the penis over the glands where the excised foreskin is. And the reason that we do that is to keep the circumcision from sticking to the diaper. We don't want a scab to form there and we put a diaper on and it sticks, that scab sticks to the lining of the diaper, and then when you do the next diaper change, you've pulled the scab off and now it has delayed healing even longer. So using petroleum jelly or some type of petroleum gauze can prevent that sticking that can occur. Typically, right after the procedure is performed, your care provider will dress it with some type of petroleum gauze. It usually comes in a sterile pack, but it keeps the petroleum in the gauze keeps it from sticking to the excised skin and also from the diaper. But it also holds pressure to prevent bleeding. You just want to make sure that it's not cutting off circulation. So we want the pressure to be enough to stop bleeding if we're using gauze or to prevent bleeding, but we don't want it to be too tight. You want to report signs and symptoms of infection and teach the parents what those are and ensure that the diaper is not too tight or too loose. We don't need to change our diapering habits other than making sure that we're using petroleum jelly the first few times so that the penis doesn't stick. Strengthening parent and newborn attachment in the transition period of the newborn is extremely important. We want to involve all the family members and all the support members of the mom in this process. We want to be very sensitive to their cultural beliefs and the values of their family. We talked in class about how Hispanics believe that pregnancy is a hot illness, but that birth itself is a cold illness. So they try to maintain a balance between those two temperatures. So after birth, Hispanics do not want ice water. They typically will be dressed very warmly. They dress their babies very warmly. They might want room temperature water. You might find Hispanics who put cotton in their ears to keep the cool air from entering their body. So being sensitive to cultural beliefs is important. And then teaching them quieting activities for the baby. So teaching them how to swaddle or bundle to increase that sense of security for the baby. Talking and using very slow and calming movements, singing and humming and doing some massage, patting them on the butt or rubbing their back in a slow motion. All of those things will help in terms of quieting activities. And if you can teach a parent in the hospital to master one of these activities for their kid, and each one of them doesn't work for everybody because we're all individualized, right? I had one child who you could put him to sleep by patting his little diaper. You could pat his back and it did not work. But if you patted his diaper, gave him a little pat pat on the hiney, while he was trying to go to sleep, he would quiet down and he would go to sleep on you so fast. But if you're rubbing his back or patting his back, that didn't work. He didn't like that. So if they can figure out what works for their newborn before they go home, we can decrease the incidents that parents are going to get frustrated, that they are going to that at least they're going to have an idea of what will work to quiet their babies down, so that when they become totally exhausted, they're not trying to find something that's going to work. Um, and hopefully that can help decrease incidents of shaken baby syndrome too. So preparing the family for discharge. Remember I said that we start preparing the family for discharge before the baby is ever even born. If the mom is in labor and she is in a state of mind where you can teach her and she will retain information as the nursery nurse, you're in there teaching her everything you can that you know she's going to remember. The nurse is responsible for this, and we want to be educating them every single time we come in contact with them. If they come to the desk and ask for a cracker and a sandwich, we want to do some type of education with them because, well, first of all, number one, if they've walked to the desk to ask you for a cracker and a sandwich and the baby is not with them and they are the only person in the room, we need to do some re-education about safety goals. So there is not one time in the hospital where you have contact with a mother, a parent, or their newborn that you don't have an opportunity to assess the situation and provide some teaching. We want to reinforce their good behaviors. So if they're doing a really good job at changing the diaper, we want to tell them they're doing a good job. If they figured out how to quiet their baby, we want to tell them you're doing a great job. That seems to be working. It's important for them to get that positive reinforcement because once they get home, they're not going to get that from anybody else. They're going to be the sole caregiver most of the time. Making sure from a religious and a cultural standpoint that you as the nurse are respectful and sensitive to your patient is very important. I can't stress that enough. We want to respect the dignity of every human being, and we want to accept the rights of individuals to be able to choose who they want to care for them, who they want to participate in that care, and who they want to refuse care from. We want to be able to acknowledge ourselves, our personal biases. We all have them, and that is okay. What's not okay is whenever a nurse is so biased that she does not recognize that in her own self. We have to be self-aware care providers because if we are aware of how we feel, we can control how we treat people. We have to incorporate cultural issues and preferences into our practices and into our plan of care. So, for example, the Hispanic patient who doesn't want ice water at the bedside, well, then get her some room temperature water. Don't just not give her any water at all. Um, you know, tweak your plan of care. Make sure everybody else knows that too. Make sure the nurse aide that you're working with knows this person doesn't want ice water. They want room temperature water. So talk to other people. Make sure that you are providing appropriate educational materials. If you have a family who is a Hispanic family and they speak English but not very well, then why pray tell, would you print them out some discharge instructions in English? If they can't speak it well, they probably can't read it very well either. Or they may be able to read it very well, but they might not understand it and be able to comprehend it in the same way as if you printed it out in Spanish. So make sure you're providing appropriate ways to educate them. Make them teach you back. Not everybody can read, and we just assume that everybody can read, and people will pretend that they can read, but they might not be able to. Um, Always, always, always be providing the highest quality care that you have the capability to provide for every patient that you take care of. So to move even further into preparing families for discharge, we want to make sure that our parent teaching is appropriate for the type of individual that we're taking care of. So we may be taking care of first-time parents or parents who already have children. Maybe they only have a girl at home and they don't know how to take care of a boy. They don't know how to diaper a boy. So you have to know your patient and individualize your teaching based on their knowledge and their experiences. Um, if they're new parents, you want to teach by example, show them, demonstrate, provide instructions, and then have them teach you back. Use every opportunity, again, every opportunity that you come in contact with the patient to teach them something. Observe how they interact with the baby. It will give you a lot of clues as to how well they are bonding and how things are going to be at home. People will always be on their best behavior in front of a healthcare professional for the most part. And especially if they know that you are watching them to make sure that they are taking care of their kids like they're supposed to, they'll be on their best behavior. But things will change when they get home sometimes. So be very astute and observant. Give them positive feedback again. Several methods can be used to teach. Many places have videos and a little class that parents have to attend prior to being discharged home. You can give people one-on-one individual instruction, which you should do for every patient. And that is the best type of teaching because you can assess their learning and you can allow them to demonstrate back and really focus on that individual. And because of hospital stays that have become much shorter than they were in times past, most teaching needs to focus on sort of those basic life sustaining measures like feeding and physical care and recognizing signs and symptoms that need to be reported. We want them to know how to place them to sleep when they go home. So putting them on their back to sleep. We want them to know how to use the bulb syringe. It's not effective to stick the bulb syringe in the nose and then squeeze it. We want them to stick it in the nose, squeeze it, and then stick it in the nose and let it go. You have to teach people these things because many people really don't know. You want them to demonstrate a bath and cord care and how to take a temperature and when to call the provider prior to them going home. You want them to tell you these things and to show you these things. For nasal and oral suctioning, we know that newborns are obligatory nose breathers. We know they have a lot of mucus and a lot of secretions in the first few days, and so we might have to gently suction them. But also, if we are constantly suctioning their nasal passageways over and over and over again several times a day, it's important to teach parents that that can actually cause swelling in the mucous membranes and make the problem worse. So we want to be gentle about using the bulb syringe, and we want to do it only when we really need to. From a nursing standpoint, newborns that have some transient edema in their nasal passageways, after they've been suctioned after birth. So sometimes if we've had to do a deep suction or do some vigorous bulb suctioning, it will cause those mucous membranes to swell a little bit in their nasal passageways. We can use some normal saline to help loosen up those secretions, and that will help, but we want to make sure that parents are aware that they need to be gentle and only use these bulb syringes when they absolutely need to, so we don't further irritate any edema that might occur or has occurred. If the individuals are going to be using a humidifier at home, we want to make sure that the parents are following the manufacturer's cleaning instructions, because parents who are using humidifiers, if they're not cleaning those appropriately, we can actually be sending out bacteria into the air that can make babies sick, and they need to be aware of that. Teaching them how to swaddle a newborn helps maintain body temperature. So nurses in the hospital will swaddle newborns for this reason, and also to help them have a sense of security and help in quieting the baby. But allowing them to have their hands out of the swaddle and sort of near their mouth will allow them to um, utilize sucking to help self-quiet. And we want to demonstrate proper wrapping techniques and have parents teach back swaddling techniques if they're going to use that at home. But nowadays, because of SIDS, we really want to encourage them to use swaddlers with Velcro, because if parents do not swaddle appropriately and newborns start to move around in bed and the swaddle becomes loose and they start moving, and that their hand movements start to move that blanket up over their face, newborns will begin to hold their breath if things get on their face. So that will increase their chance of experiencing some respiratory depression and some worse outcomes if not caught. Sleeping, making sure that we're teaching safe sleep to parents is important, and teaching that every single time. Um, Also letting them know that every baby has their individual sleep activity cycle. No one of their children, if they've had multiple ones, will ever be the same. And nurses can help parents to recognize and develop a sensitivity to their babies' sleep cycle, and also to their communication signals regarding needs for feeding and changing. We can help facilitate that process before they go home. Hearing screens, like I mentioned earlier, are provided to parents or to newborns prior to discharge. We like for every newborn to have a screening, and if they fail their hearing screen, we will schedule follow-up appointments for those babies in a few days at the pediatrician's office or at the audiologist to be able to be re-screened. We want parents to know about car seat safety. Newborns have to go home in a car seat that is adapted to fit a newborn. We should never place it in the front seat, and never place it somewhere that is close to an airbag. The car seats have to be rear facing until the baby is 2 years old, and that is a new law change. It used to be just 1 year. It's now 2 years, and parents are very upset, and most parents will be very upset about that, but we have to educate them on what the law is. Um, Not only do newborns receive a hearing screen, but they also receive a newborn metabolic screen called PKU testing. PKU stands specifically for phenylketonuria, but PKU testing that is sent to the state lab tests in North Carolina for about 26 different congenital problems and metabolic disorders. Um, you can educate parents that no news is good news. But if one of those tests come back abnormal, they will get a certified letter in the mail and they will be asked to have their baby rescreened. Um, those PKU screenings have to be done um, at 24 hours of age. So we don't do those tests prior to 24 hours. We all play a role in taking care of families and uh, their new little babies. We need to be cognizant of our community and different resources within the community to be able to educate parents about. So we want them to be able to access community-based nursing care if they need that once they go home. We want to link them up with a provider so that they can schedule a newborn visit after they go home. We want them to know when they should call their pediatrician. Um, so we want them to know signs of illnesses and signs of distress. We want them to have the contact information they need so that they can make an appointment and make that phone call if something goes wrong once they get home. Um, and there are many hospitals around that actually do follow up home visits. So there is a specific nurse who is dedicated to visiting the newborn that is discharged within 48 hours after going home or 48 hours after birth, especially for the newborns who are discharged prior to 48 hours. Um, and that's really helpful because what those nurses focus on is normal newborn care. They look for jaundice, they assess the baby's weight, and they talk to the parents about feeding and try to identify any feeding problems that might be occurring. And they educate them on things that they might assess uh, where they have gaps in their knowledge related to newborn care or feeding. So it's a really good program, and many hospitals have implemented it. So, what do you expect? We expect that the newborn will adapt to extrauterine life successfully. We expect that their physiologic and their psychologic integrity is supported, um, and that there are positive interactions between the parent um, and the infant and any support partners or people, that the feeding pattern in the baby has been satisfactorily established prior to going home, that the parents express understanding of what the bonding process is, and that they are actually displaying those attachment behaviors prior to us sending them home. We want to demonstrate safe techniques when we care for the newborn so that the parents have a good role model and will also pick up techniques that are safe for the baby in terms of care. We want the parents also to verbalize developmentally appropriate behavioral expectations of the newborn and have knowledge of community-based newborn follow-up care providers or support groups or organizations. And if the outcomes that we expect are not met, we can continue to revise a plan of care. And so for your home visit nurses, um, they might see the baby one time and things are going great and we don't need another follow-up visit. But for those who are having complications, your home visit nurse might end up scheduling another visit or scheduling a doctor's appointment or creating some type of community-based awareness and collaboration with the healthcare team so that we can prevent any complications from occurring. But obviously, in the end, our expected outcome is a healthy mom and a healthy baby. So let's move through newborn complications and high-risk newborns really quickly. There is a group of high-risk newborns, and this by no stretch of the imagination is an all-inclusive list of what high risk means, or all of the high-risk classifications for newborns. But gestational age can put newborns at high risk, ones that have low birth weight, premature, preterm newborns, ones that are born too late, newborns that are infected, that have an acquired infection after birth, or ones they were born with. Newborns that have congenital anomalies or had mothers that were substance abusers, newborns who have physical injuries from the birth process or metabolic disorders, or newborns from moms who had some type of chronic illness or intrapartum insult that happened during labor and delivery. So the list goes on and on, but that is a few of the main ones. So when we think about high-risk newborns related to gestational age, there are four sort of categories that we think about. We think about small for gestational age babies, very small for gestational age, large for gestational age, and then babies who have intrauterine growth restriction. Our small for gestational age babies have very small body dimensions. They have reduced body fat, which puts them at risk for inability to thermoregulate appropriately. They will have a drawn-looking abdomen, kind of like this little fella in the picture. They have loose, dry skin. They will be hypothermic, potentially, if you don't support their thermoneutral environment. Their sutures may be separated on their head. And they are at a greater risk to be hypoglycemic because of their condition. They may be struggling to keep their temperature up, and that's what's causing them to be hypoglycemic, or it can just be hypoglycemia because of their being small for gestational age, or SGA. So to define a kid as SGA, their birth weight has to be at or less than the 10th percentile. And small for gestational age babies can be preterm, they can be term, or they can be post-term. So it's not secluded to a certain gestational age group. It just has to do with what percentile they fall into based on their weight. Causes for small for gestational age babies include smoking, drugs and alcohol, anything that causes some type of decreased perfusion in the placenta or malnutrition, and also babies that are multiple gestation. You may have one that's average for gestational age or appropriate for gestational age, and then you may have one that is small for gestational age if you have twins, because they have to struggle especially if they're mono twins, because they have to share the placenta. Complications of some of these SGA babies include perinatal asphyxia, meconium aspiration syndrome. These guys might be hypoglycemic, so we consider that less than 45, less than 40 in some facilities. They might have polycythemia, so greater than 65% RBCs. And then we move over to our large for gestational age babies. And these guys are big, but don't let them fool you because they are immature. They are looking big on the outside and nice and mature, but on the inside, they are very underdeveloped, and their systems they don't tend to do very well if you um, from an adaptation standpoint to extrauterine life. So this is your baby who weighs at or above the 90th percentile. So that's 4,000 grams or more, which means more than 9 pounds. And usually these guys will be delivered by C-section because they are macrosomiacs, and typically there'll be some type of cephalopelvic disproportion that hinders them from being born vaginally. Not always, but most times. And although they have that big size, their organs, especially their lungs, tend to be more immature. They have way too much subcutaneous fat. They have hypotonic muscles and tend to be lethargic. They will show signs of hypoglycemia and polycythemia. They'll also be hypocalcemic. And these guys are also at risk for physical birth injuries. So, especially if you have a macrosomiac baby that is trying to be born vaginally, they're at a greater risk for shoulder dystocia. So getting the head through the birth canal, but the shoulder gets stuck on the symphysis pubis, and that can delay the second stage of labor and cause it can cause a broken clavicle. It can cause Erb's palsy and all kinds of other physical birth injuries. And that's not the only type of physical birth injury that we talk about, but that's sort of a main one that we see in LGA babies. Risk factors to make you an LGA baby would include infants that are born to mothers who have gestational diabetes or who are just regularly chronically diabetic. Genetic factors. So if your mom typically has large babies, that puts her other large. I have an aunt who is a very teeny tiny lady. She is about 4 foot 11 inches, and she probably weighs 100 pounds. And she had 3 girls. They were all pretty large, but the last one weighed over 11 pounds, and she had her vaginally. So it's possible to do, but there can be a genetic component to that as well. Also, moms who have more than one kid, so your multiparous moms, especially if they have not had a long period of time between pregnancies, their babies for every subsequent pregnancy tends to be a little bigger than the last one. Moms who have obesity, and you don't have to really worry about Beckwith-Weidman syndrome. It's a genetic disorder that causes babies to overgrow, basically. And also, LGA babies are at a greater risk for a congenital heart anomaly called transposition of the great vessels. Your post-mature infants are those infants that are born at or after 42 weeks old. These guys can be SGA or LGA. They typically will not have any glucose reserve because the placenta starts to die out around 42 weeks or even a little before then. So they are not getting the nutrients that they would typically get for a placenta that was still viable. So they don't have a lot of glucose reserve and tend to be hypoglycemic when they're born, or at least experience it after birth. They also may be at a greater risk for perinatal asphyxia or hypoxia in utero because of the viability of the placenta not being appropriate at that age, that gestational age. These guys, if they experience hypoxia in utero, will tend to release meconium. Intrauterine gathering my thoughts. So if babies experience hypoxia, they tend to release that sphincter and allow all that meconium to just spill out while they are inside mom. And if that happens, then these guys are at a greater risk for meconium aspiration syndrome because the placenta starts to die out in at a certain number of weeks. Post-mature infants are at a greater risk to experience this than some others. Birth trauma can happen, especially if they're an LGA baby, and they're also at risk for temperature instability as well. These guys typically have a really long, thin body. They look a little wasted sometimes. Their skin might be thin and dry, it might be peeling and cracking. Their hair and their nails have grown, and they might be really, really long. And if they've had meconium in their fluid, their nails and their skin might even be stained, like a yellow color. Um, Again, they tend to be hypoglycemic and hypothermic. There are lots of congenital anomalies, and I've listed some of the main ones here for you. All of these are included in your ATI book, and I would like for you to look over those and just have a general understanding of what these different congenital anomalies are. I would like to sort of highlight cleft lip and cleft palate, diaphragmatic hernia, and gastroschisis. We'll talk about cerebral palsy when we talk about growth and development, but if you have a patient who has a cleft lip or a cleft palate born that way, those guys are at risk for aspiration whenever they're feeding because they don't have that palate to be able to support the fluid going in the correct spot. And that's sort of the same, that's kind of the same also with tracheoesophageal atresia as well. They're at risk for aspiration. For the cleft lip and the cleft palate, those guys will eventually have surgery, but they will not have it right away. So being able to support nutritive efforts and nutrition for those babies is paramount. And we use special nipples, and we teach parents how to utilize that special nipple and put it past the defect so that the fluid is entering the newborn past the defect instead of at the defect or before the defect, so there isn't as great of a risk for aspiration in these kids. We want them to stay upright to eat. We want them to stay upright after eating because we want to decrease that risk for aspiration as much as possible. For kids who have diaphragmatic hernias, so that's a hole in the diaphragm, and then the bowels will come through and be in the chest cavity. That is incompatible with life unless it is fixed very quickly. So recognizing that as a nurse would be very important. So if you're hearing bowel sounds in the chest cavity where you should hear heart or you should hear lungs, that could indicate to you that there's some type of diaphragmatic hernia. Also, if you notice that the chest wall is not rising like it should, because if bowels are in the chest cavity, it's going to displace the ability of the lungs to be able to expand. And we also know that we need our diaphragm to expand our lungs as well. So if there's a hole in it, and now our bowel is also pushing, taking up room where our lungs can expand, these guys are not going to ventilate. You're going to see respiratory issues very, very quickly. And that requires immediate surgery. Gastroschisis kids, they are born with their bowels on the outside of their abdomen. They've got a hole in their abdomen, and their bowels will come out of that. If they are born that way, the most important thing to do is to try and prevent infection for these guys. So and keep that bowel from drying out. So wrapping that bowel in some moist, sterile towels that have been sterile water, sterile towels, keeping them moist, placing them in some type of sterile bag. We actually have bags that are made to put bowels in, and many hospitals have that. But if you don't, trying to utilize the sterile towels and the sterile saline to keep those bowels nice and moist until they can have surgery. And those people would go to a tertiary care facility where they could have surgery pretty quickly. We wouldn't want to feed those babies who have bowels that are poaching out of their stomach. But I want you to look in ATI and go through each of these congenital anomalies and pick out some of the really appropriate nursing measures. There are also certain metabolic orders, and I've highlighted kind of three sort of main ones that we see. And still they're very, very rare, but phenylketonuria is one, and that's an error of protein metabolism. We also shorten that so we don't have to say that terrible word, and we will call it PKU instead. But it's an error of protein metabolism. What happens is phenylalanine in these kids cannot be converted into tyrosine, and it starts to accumulate in the brain, causing brain damage and mental retardation. So all we have to do is give these guys a supplement, a dietary supplement, and then they're going to be fine. These types of disorders are what we test at the state lab whenever you do the PKU testing at 24 hours. For newborns in the hospital. Maple syrup urine disease is a defect in the body's utilization of amino acids, and it has a very rapid progression, and if it's not treated, it will be fatal to newborns. Galactosemia is an error that happens in carbohydrate metabolism, and these newborns have an inability to utilize galactose and lactose. And that once that starts to build up, it will cause cataracts and liver and brain damage. So we want to treat these guys as quickly as we can. And then we get into newborn conditions that become emergencies. So any newborn who is experiencing some type of asphyxia will lead to respiratory distress and prolonged apnea, and then eventually cardiac arrest. So if you have a newborn who is experiencing some type of respiratory distress or prolonged periods of apnea, so greater than 20 seconds, we want to correct that immediately. We want to intervene. That's an emergency from a newborn standpoint. If you have a kid who is grunting or retracting or flaring, you have to intervene quickly because they will deteriorate on you very, very rapidly to a point that they end up in cardiac arrest. Individuals that are born with meconium aspiration syndrome, those guys have to be treated a little differently. We want to be doing some antibiotics if they are experiencing complications from that. So if we have an x-ray and we suspect meconium aspiration syndrome, it looks very much like pneumonia on an x-ray. We would want to treat it prophylactically with antibiotics, and we would want to support respiratory efforts for kids that are struggling. For transient tachypnea of the newborn, or TTN, that is just an inadequate clearing of the airways. So if the fluid is not reabsorbed during respiratory adaptation, some newborns will start experiencing TTN. It also shows up on the x-ray kind of like pneumonia as well. So you'll be able to see fluid in the lungs on the x-ray. And for those guys, we want to promote oxygenation. And we also can treat that with antibiotics prophylactically as well until they have a blood culture and that blood culture is clear. So we don't want to look at transient tachypnea of the newborn on an x-ray, believe that it's transient tachypnea of the newborn, not treat it, and then it ends up being something more serious like meconium aspiration syndrome or some type of pneumonia. Um, Back to meconium aspiration syndrome. For those kids, we want to reduce their oxygenation demands as much as possible. Sometimes these guys have to be on an oscillating ventilator. Um, we want to avoid positive end expiratory pressure if we're giving if they are on the ventilator, or if we giving them bag and mask resuscitation, because we don't want to force meconium any further into the lungs than it already is. Um, Down to cold stress and hypothermia. We know that cold stress and hypothermia will kill your baby. It will lead to respiratory distress, which will eventually lead to cardiac arrest. So, providing warming efforts and reducing oxygenation demands, and then supporting oxygenation for babies who are in hypothermic or cold stressed states is very important. Um, in in the newborn who is experiencing hypoglycemia, we want to provide nutrition. We want to feed them first, and we want to reduce their oxygenation demand. So we want to make that feeding as easy as possible for them. If your newborn is too hypoglycemic or too sick to actually bottle feed or breastfeed, then we better be getting an IV and providing them with some D10, some D5, or some D10 through that line. Polycythemia is, as you know, an abnormally increased hemoglobin level. And in response to that, you might have a newborn who starts to experience jaundice, possibly some CHF, and for poor feeding. So we'd want to be assessing them for those things. And for your newborn who has narcotic sedation, we used to use Narcan to be able to bring them back quickly, but it has been proven to cause pulmonary edema in the newborn. And so the American Academy of Pediatrics has recommended that Narcan no longer be used for newborn patients. So now we just support their respiratory efforts and wait for that medication to wear off. When it comes to the etiology of why poor oxygenation and tissue perfusion occur in newborns, we can look at a whole lot of different areas, and these again are not all inclusive, but give you a clue and an understanding of how some of these poor oxygenation and tissue perfusion things happen in a newborn. If there are placental problems such as an abruption or bleeding from a previa, that can affect the oxygenation and tissue perfusion of your neonate. If there are umbilical cord issues, so maybe there is just one artery and one vein. If there is narcotic use in the mom, if the nurse has created poor timing with her implementation of analgesia of the laboring patient. So we've given narcotics to the mom closer to the transition phase of the first stage. Or either we've had a precipitous delivery after giving some narcotics to mom. If mom has had a hemorrhage intrapartally, she's got some kind of infection, the baby is premature, or we've got multiple births going on. All of those things can affect oxygenation and perfusion in your newborn. Anything that will decrease perfusion to the fetus during labor will cause this. And any type of immaturity in the respiratory center and the lungs for the newborn can also cause this. So a lack of surfactant, or alveoli that collapse, or meconium that's in the lungs that don't allow the alveoli to open or take up space there. Airway obstruction because of mucus secretion or aspirated meconium, cold stress. All of these things can contribute to poor oxygenation and tissue perfusion in your baby. So, what are some interventions that we can utilize knowing that these are some issues that cause this in the newborn. Well, these are not in order of priority, by the way, so don't look at it that way. But from a nursing standpoint, we want to be always monitoring the oxygenation status of our fetus. We want to suction and secrete any type of, secretion or mucus that might be occurring in the nasal or the oropharyngeal passageways that the baby is not able to get out on their own. We want to keep their head in a sniffing position if they're having trouble. We want to, because that helps open up the airway, right? If we can, I mean, just like CPR, you put the head in a sniffing position, it opens up the airway. Same thing in a newborn. And if they're having problems, we want to support them in every way that we can, even from a position standpoint. We might have to administer some oxygen. We might have to do that by blow-by. We might have to put them on a mask. We might have to put them under, we usually don't use a mask for newborns, but we use something called an oxy hood, which is like a big giant mask that goes over the entire head. We might have to intubate and give oxygen that way. We want to make sure that we promote thermoregulation and keep that baby warm and dry so that we don't potentiate any type of oxygenation or hypoxic problem that is already going on. If they have hypoglycemia, we want to monitor that and we want to correct it as soon as possible. Again, so that we don't potentiate that triad of hypoglycemia, hypothermia, and hypoxia. We want to support their respiratory efforts, especially if they have some type of narcotics on board. We want to administer antibiotics if there's a chance that the baby could be septic or exposed to infection. We want to promote bonding for that baby and support the parent attachment and care as well, and make sure that we've educated those parents. If your baby is having respiratory distress, we are not going to feed them. We are going to start an IV and we're going to give them some D10 or some type of hypertonic IV fluid that will increase their blood sugars. You want to make sure that in the presence of any type of respiratory depression or respiratory compromise that you have resuscitative equipment available. You want the appropriate size ET tubes. You want a laryngoscope with a light that works. You want to make sure that you have the appropriate size bag and mask. And making sure that you're prepared for an emergency, especially if you're dealing with a maternal patient who is already who is under some type of condition that will cause your newborn to be high risk. You want to make sure that you are prepared for what could happen. And that is all part of being a good nurse, not just in maternal and newborn care, but all around. So this is the end of Lecture 3 for Individual Module 6, where we're talking about newborn care. And I appreciate you listening. Talk to you next time.